let's go. If you could gaze into a suture, you might think the brain is such a breeze. Brain is a breeze. Breathing from a distance, yeah. Go Jay, but it's not that easy. Oh no, they try to study brain behavior and they end up brain assessing. Hey now, ADL now, about to put the gown and assess your cognitive level now. Diagnosis is clear now. Rehab unit or clinic now. Let's go. That's so neuro. It's a brain they try to see. That's so neuro. They like to work with OT. That's so neuro. It's a brain they try to see. That's so neuro. They like to work with OTs. Yeah. Yep, that's me.
Hello, Celine.
Yes.
Hi, it's Dr. Rinku.
Oh, hi, Dr. Rinku.
How are you?
Good, how are you?
I'm well, thank you.
Okay, first question. What is a neuropsychologist?
Well, a neuropsychologist is a clinical psychologist with a specialized training in the field of neuropsychology. Which means that they have their internship experience, at least their internship experience, which is the year that you have while you're in graduate school. And their postdoctoral fellowship in neuropsychology. So that refers to their training, and they could have their dissertation or their classes that they've taken, several of those. So that's what a neuropsychologist does in terms of training. In terms of what a neuropsychologist does, several things, but essentially it's someone who looks at cognitive functioning. Okay, cognitive functioning based on certain tests that we give people to look at different cognitive domains. So like their attention, their memory, their processing speed, their visual spatial abilities. And really, tests are given. They're very purpose-driven, obviously. They're very referral-based driven. And you're trying to number of things. You're either trying to find out, what the diagnosis is. So for clarification of diagnosis, like a neurological condition or a neuropsychiatric condition. So clarification of diagnosis, and definitely in terms of treatment recommendations, whether it be medications, whether it be radiological scans, whether it be behavioral changes, whether it be like psychological interventions. A neuropsychologist also looks at not just diagnosing, but also coming up with recommendations that could help the person potentially. In very general terms, that's what a neuropsychologist does.
Okay, so what are the educational requirements of a neuropsychologist?
What it is it's specialized, education in your graduate program, internship, fellowship, and then after that, it's your just personal career path that you choose to take or not to take.
Got it.
So yeah.
Okay, so next question. So what settings do neuropsychologists typically work at?
Oh, all kinds of settings. So you can have like forensic settings. Psychiatric forensic hospitals and things like that. So forensic settings in the forensic field a lot. So you can do private practice work, doing a lot of forensic work. Then obviously with any kind of hospital setting, where in a rehabilitation unit, such that I'm in. Or a neuro unit, or a dementia unit, like even if it's like a inpatient psychiatric unit, a neuropsychologist could work there to help differentiate, neuro problems or psychiatric problems, and that could be a very valuable input. And obviously, I work with adults, but obviously, neuropsychologists working in pediatric settings, so in regional centers, in schools, once again, we talk about hospitals, but like children's hospitals, both in the inpatient and outpatient department. So yeah, lots of different kinds of settings.
Okay, so when would an OT typically refer a client to you?
With occupational therapists, they have I love the field, and I think they have a very keen insight and viewpoint with regards to the person's psychosocial functioning. So if I'm not engaging in ADLs, or my pain is stopping me from making myself a meal in the morning or driving, then immediately the occupational therapist should ask questions with regards to, so how does the pain affect you, and then to sort of like really see if there's an issue of depression or anxiety, low motivation. That could be also compromising the reaching of treatment goals. Another place an occupation, so that is just with like, for example, something like pain. But another area that an occupational therapist should always look for is cognitive changes. So patients having a decline in doing their ADLs and IADLs. Why? Is it because they are, they're having a change in their cognitive mentation? Is it because of depression, because of something else? So really sending to a neuropsychologist to try to find out, hey, what's going on? Could you please, maybe tell us, explain to us, or maybe investigate why the person would have difficulties in, making a sandwich for themselves or taking the pills. So I think that information is really valuable in terms of not just cognitive functioning, but obviously neurological functioning as well, visual spatial functioning. So, here they're shaving, but they're only shaving their right side, Obviously I don't think you need a full-blown neuropsychological evaluation to get the person has a left neglect, because of a right CVA or something that's going on in their right hemisphere. But I think it's also helpful saying, okay, if this is a neglect pattern, what else could it be affecting? Is it affecting their insight? And insight is a big thing with occupational therapy, because we're trying to get people to change, and we're trying to get people to, occupational therapists are trying to, improve their quality of life. And so do they have the insight that this stuff even wants to change,
Right.
So those kinds of things are really helpful to have neuropsychological opinion on, with regards to, okay, this person had a stroke, these are the areas that we're working on. Are these even reasonable goals? Or is it like, are we setting up the person for failure by setting these really high goals? Do you see what I'm saying?
Sounds good.
Okay.
Thank you very much, Dr. Rinku.
You're welcome. All right, Celine, Jackie, take care of yourself and best of luck.
Thank you very much. Have a good day.
Okay, bye-bye.
Bye.
And then